راديولوجي جلوبال. ونبتدي يا دكتور طارق ان شاء الله نستمتع ونسمع الاخت الدكتوره عبير جبر على التوبيك بتاعها المهم اللي هو Imaging of Pediatric COVID-19. اتفضلي يا فندم.
السلام عليكم.
وعليكم السلام.
شكرا جزيلا على المقدمة الجميلة جدا. النهاردة إن شاء الله هنتكلم على الكوفيد 19 what pediatrician needs to know. I'm Abeer Gabr, assistant lecturer at Inshams University Hospital. Today, inshallah, we will discuss clinical presentation, diagnosis, and standard radiology report for COVID-19. COVID-19 coronavirus disease 2019 is an infectious disease caused by severe acute respiratory syndrome coronavirus 2. The current outbreak was officially recognized as a pandemic on 11 March 2020. Clinical presentation including fever, cough, fatigue, sputum production, and shortness of breath. Less common symptoms including myalgia and arthralgia, headaches, sore throat, chills, and pleuritic pain. Other symptoms include nausea and vomiting, diarrhea, anosmia, conjunctivitis, and skin rash. Pediatrics tend to have milder symptoms than adults, and symptoms could be similar to any acute chest infection. PCR is considered the gold standard for diagnosis of COVID-19 pneumonia. Radiology.
Dr. Abeer, please kindly raise your voice.
حاضر تمام. According to the American College of Radiology appropriate criteria, imaging is not indicated in a well-appearing immunocompetent child more than 3 months of age who does not require hospitalization. However, if the child is not responding to outpatient management, requires hospitalization, or is suspected of having hospital-acquired pneumonia, chest X-ray is considered the most appropriate first step in imaging evaluation. Chest X-ray should be considered in pediatric patients with suspected COVID-19 presenting with moderate to severe acute respiratory illness symptoms. According to international expert consensus statement on chest imaging in pediatric COVID-19 management, this consensus statement is based on expert opinion from 6 pediatric thoracic radiologists from 6 countries across 5 continents from United States, Spain, Hong Kong, Brazil, South Africa, and United Emirates. They designed standardized reporting of imaging findings for COVID-19 in pediatric patients. The radiology report includes the level of suspicion of COVID, either typical appearance, indeterminate appearance, atypical appearance, negative for pneumonia. Typical including commonly reported chest X-ray findings of COVID pneumonia in children. And this includes bilateral distribution, peripheral and or subpleural, ground glass opacity and or consolidation. These imaging findings are commonly seen with COVID-19 pneumonia in children. Differential diagnosis also include other viral or atypical pneumonia. This 16-year-old female with tuberous sclerosis and positive COVID-19 PCR test who presented with acute hypoxic respiratory distress. Frontal chest radiograph shows bilateral lower lung zone, predominant consolidation, and ground glass opacities, which is typical chest X-ray findings of pediatric COVID pneumonia. Indeterminate. They are non-specific chest X-ray findings of pediatric COVID pneumonia. This includes unilateral peripheral or peripheral and central ground glass opacity or consolidation, bilateral peribronchial thickening and or peribronchial opacities, multifocal or diffuse ground glass opacities and or consolidation without specific distribution. These imaging findings can be seen with COVID-19 pneumonia in children. However, they are non-specific and differential diagnoses include both infectious and non-infectious etiologies. This is a 15-year-old female with asthma and positive COVID-19 PCR test who presented with fever and respiratory distress. This frontal chest X-ray shows ground glass opacities in both peripheral and central distribution, which are indeterminate chest X-ray findings of pediatric COVID pneumonia. Also noted the right apical pneumothorax. Atypical, they are uncommon or not reported chest X-ray findings of pediatric COVID pneumonia, and this include unilateral segmental or lobar consolidation, central unilateral or bilateral ground glass opacity or consolidation, single route consolidation with or without air bronchogram, pleural effusion, and lymphadenopathy. These imaging findings are atypical or uncommonly reported in cases of COVID-19 pneumonia in children. We recommend consideration of alternative diagnosis. And this 9-year-old female with renal transplant and positive COVID PCR test who presented with respiratory distress. Frontal chest radiograph shows consolidation in the left lower lobe, which is atypical for pediatric COVID-19 pneumonia. Also, a 4-year-old male with fever and respiratory distress. Frontal chest radiograph shows a round consolidation in the medial right upper lung zone, which is atypical for pediatric COVID pneumonia. This patient round pneumonia was due to bacterial infection. Negative, no chest X-ray findings suggestive of pneumonia in children. Note that chest X-ray has a limited sensitivity for COVID-19, especially in early stages. Chest CT. Current recommendations for chest CT in pediatric patients with suspected known COVID-19. Chest CT is not recommended as initial diagnostic test in pediatric patients with suspected COVID-19. So, what are the indications of chest CT? Chest CT may be considered in pediatric COVID-19 patients with a worsening clinical course and or who are not responding appropriately to supportive therapy. It may be considered to answer a specific clinical question in acute setting, for example, to exclude pulmonary embolism in a patient with an elevated D-dimer. Finally, follow-up chest CT may be helpful to assess for development and or evolution of fibrotic lung disease in patients with persistent alteration in pulmonary function test following resolution of the acute infection. So, what are the risks of performing CT routinely? First, depletion of resources, especially personal protective equipments. Increased risk of viral transmission to staff, patients, or carers, as COVID-19 positive and negative patients come in close proximity in the radiology department. Additional ionizing radiation exposure. CT protocol recommended for patients suspected with COVID, including patients requiring CT should receive a non-contrast chest CT unless iodinated contrast medium is indicated, with reconstruction of the volume of 0.625 millimeter to 1.5 millimeter slide thickness, gapless. If iodinated contrast medium is indicated, a non-contrast scan should be considered barrier to contrast administration, as contrast may impact the interpretation of the ground glass opacification pattern. Imaging findings of COVID-19 on chest CT in pediatric patients. Pediatric patients tend to demonstrate milder imaging findings compared to adults. They had a lower total number and smaller size of pulmonary lesions compared to adults. The most common findings are bilateral, peripheral and or subpleural ground glass and or consolidative opacities, often in the lower lobes of the lung. The halo sign, which is a central consolidation surrounded with a halo of ground glass opacity. Peribronchial thickening and inflammation along the bronchovascular bundle are observed more frequently in the pediatric population compared to adults. Fine mesh reticulations and crazy paving sign have also been reported, although with less frequent than adults. Pleural effusion and lymphadenopathy, which are rare findings. Again, radiology reports include the level of suspicion of COVID pneumonia, which is typical, indeterminate, atypical, and negative for pneumonia. Typical, which are commonly reported CT findings of COVID-19 pneumonia in children, and this include bilateral, peripheral and or subpleural, ground glass opacity and or consolidation in lower lobe predominant pattern, and halo sign. These imaging findings are commonly seen with COVID-19 pneumonia in children. Differential diagnoses also include other viral or atypical pneumonia, hypersensitive pneumonitis, and eosinophilic lung disease. In addition, the fungal infection in immunocompromised children when halo sign is present. Indeterminate, they are non-specific CT findings of pediatric COVID-19 pneumonia. This include unilateral, peripheral, or peripheral and central ground glass opacity and or consolidation, bilateral peribronchial thickening and or peribronchial opacities, multifocal or diffuse ground glass opacities and or consolidation without specific distribution, and crazy paving sign. These imaging findings are seen with COVID-19 pneumonia in children. However, they are non-specific, and differential diagnoses include both infectious and non-infectious etiologies. Atypical features, they are uncommon or not reported CT findings of pediatric COVID pneumonia. And this includes unilateral segmental or lobar consolidation, central unilateral or bilateral ground glass opacity and or consolidation, discrete small nodules, centrilobular triumbot, lung cavitations like abscess, pleural effusion, and lymphadenopathy. These imaging findings are atypical or uncommonly reported in cases of COVID pneumonia in children. Recommend consideration of alternative diagnosis. Negative, no CT findings suggestive of pneumonia in children. But we say that CT may be negative in early stages of COVID-19. However, according to this paper published in 18 June 2020, 22 articles were included in this systemic review and reporting chest imaging findings of 431 children. At diagnosis, 34% had a normal CT. Abnormalities were more common in the lower lobes and were predominantly unilateral. The most common imaging pattern was ground glass opacification in 62.4% of the patients. None of the studies described lymphadenopathy, while pleural effusion were rare. To summarize, according to multinational consensus statement from Fleischner Society and international expert consensus statement on chest imaging in pediatric COVID-19, there are three scenarios. The first scenario, mild features. These pediatric patients in this group often present with in the outpatient setting with mild clinical symptoms, such as fever, cough, and or rhinorrhea. In this situation, COVID-19 test with PCR should be the first step in the screening evaluation. If COVID-19 testing is not readily available, these pediatric patients should be stratified into suspected COVID positive group in endemic areas with known community spread and suspected negative in location with low disease prevalence. Given the overall milder clinical course of COVID-19 in the pediatric population and the increased radiation sensitivity of pediatric patients, imaging is not recommended for the majority of the patients in the mild group at the time of presentation, regardless the PCR results. However, if the patients with positive COVID, either by laboratory diagnosis or presumed positive status based on local disease prevalence, with underlying comorbidities like asthma, congenital heart disease, and chronic infection, placing them at risk of disease progression, chest imaging is recommended to serve as a baseline as well as evaluate for alternative diagnosis, possibly related to more comorbid conditions like pulmonary edema and congenital heart disease. Even in pediatric patients with elevated risk of progression, chest CT is not recommended at the time of presentation for diagnosis of COVID-19, but may be considered in cases of clinical progression, inadequate clinical improvement, or when alternative diagnosis such as pulmonary embolism necessitate further evaluation. Regardless the underlying clinical risk factors of COVID-19 disease status, worsening respiratory function in a pediatric patient initially considered to have mild clinical features is an indication for further evaluation with chest imaging. The second scenario, moderate to severe features with no significant resource constraints. Pediatric patients with suspected COVID-19 in this group present with clinical signs for more serious respiratory compromise, including moderate to severe dyspnea, hypoxemia, symptoms such as chest pain or tachycardia or hypotension. COVID testing with PCR is initial screening test recommended for this group without resource constraints. If testing or timely results are not available, so imaging is indicated. Regardless of COVID-19 status, chest X-ray is recommended for initial evaluation of the pediatric patient presented with moderate to severe clinical features, to establish imaging baseline and to evaluate for alternative diagnosis. Chest CT may be considered in this group if the outcome will impact the clinical decision making. However, should not serve as a screening examination to assess COVID-19 status. The third scenario, moderate to severe features with resource-constrained area. If rapid COVID-19 test is available, we will do it. If not available, imaging is indicated. Given the limited sensitivity of chest X-ray, chest CT specifically tailored to low-dose technique for pediatric patients closely following the ALARA as low as reasonably achievable principle may be considered for assessment of this group either initially or following unrevealing. If no alternative diagnosis is identified and imaging findings are non-specific but extensive enough to be worrisome, the hospital will then have to make triage decisions related to concerns for COVID-19 based on overall clinical picture, local disease prevalence, and non-resource limitations. Our experience in Eldemer-Dash hospitals after reviewing confirmed COVID-19 pediatric patients. This is a 5-year-old female patient. Her CT shows bilateral peripheral ground glass opacity and consolidation together with right lower lobe halo sign, which is typical appearance of COVID-19. This is a 6-year-old female patient with acute lymphocytic leukemia with diffuse ground glass opacity lacking specific distribution, which is indeterminate appearance of COVID-19. Also, this is a 5-year-old male patient with leukemia. His CT shows unilateral peripheral consolidative patch, which also indeterminate appearance of COVID. This is a 12-year-old male patient suspecting lymphoma with left unilateral segmental consolidation with bilateral pleural effusion, which is atypical appearance of COVID. This is a 5-year-old male patient suspected lymphoma with multiple bilateral suspicious lung nodules, yet atypical for COVID-19. And negative CT chest. This is a 3-month-old female patient presented with encephalitis and tested positive for COVID by PCR, but her CT chest shows negative appearance for pneumonia. I would like to thank Professor Shaima Abdel-Sattar, who helped me a lot in preparing this presentation. And thank you. Any questions?
Thank you very much, Dr. Abeer. Thank you very much, Dr. Abeer, for your nice and comprehensive talk. Actually, you covered a lot of topics and a lot of ideas. We always ask about it. I think there is a lot of questions for you at the end of the session. And now it is honorable for me and pleasure to introduce one of the dear professors and friends, Professor Dr. Khalid Abou Futuh. Professor Dr. Khalid, an eminent figure, not only for radiology, but also for pediatric radiology. I think, and I remember that there is clinical